Hello, now we will continue with radiotherapy of prostate cancer. In this part, the focus is locally advanced PCA and postoperative treatment. In the second part of my lecture, I will give you a comprehensive overview about high-dose rate brachytherapy in the treatment of prostate cancer and the treatment of advanced stages. That means radiotherapy after radical prostatectomy, and at the end an overview over the possible side effects. Again, we will see here the outline, and we will start with HDR, that means high-dose rate brachytherapy. And the first point is that you can understand the technique that is used in the case of HDR brachytherapy. And in this very nice publication coming from Brachytherapy in 2014, you can see that at first you have in spinal anesthesia the catheter insertion, then you can make the CT for the CT treatment planning, and the way then at the end is that the treatment will be done by the high-dose rate brachytherapy. Again, looking for the technique, you can see here the needles implanted by the catheters, and then you can see that the needles will drive into these catheters during irradiation, showing here, and the dose distribution here shows again very nicely that you can spare the urethra by the treatment technique very nicely, and that you have a very deep decrease of the dose to the rectum, which is shown here by the ultrasound, by the transrectal ultrasound. And when you take a look here, you can see how the urethra passes through the prostate. However, there are some pitfalls, and it's very nice to see one of these pitfalls that can happen in this paper, also coming from brachytherapy. And you see the planned way. You see here the rectum, you see here the catheters lying in the prostate with the needles lying inside the prostate, and you can see that due to an unrecognized inferior catheter displacement, you can see that it comes away from the rectum, it comes out of the prostate needles, and during the irradiation the prostate should not be correctly irradiated. So pitfalls are always possible in this treatment form, and it's very important that these who do this treatment are very experienced in this field. What can be achieved with high-dose rate brachytherapy in combination with external beam that is typically normal-wise? So this is the phase 3 trial coming from Peter Hoskin from the UK, only 220 patients. And in the experimental combined arm, you can see they had, in addition to the percutaneous irradiation, additionally 2 times 8.5 gray, a very high single dose, during 25 hours. So the biological dose is much more higher than the total dose of 55 gray given here. Median follow-up was 30 months, and the median time to progression was significantly reduced in the group of patients who were treated with the combined treatment. You can see very clearly here. The point, however, is in this relatively old randomized trial, which is the only randomized trial what we have for the moment, you can see that the external beam dose was not sufficient, with altogether 55 gray with hyperfractionation, and so this is no clear point that the combined arm plus brachytherapy is better, because the comparison arm has insufficient dose. There are recommendations published in 2013 of the European group of radiation oncologists, and these are the recommendations with an update there. And what I want to show you very briefly is only that you have a lot of different treatment regimens. There is no consensus what is the best form how to treat these patients, and it's Here in the forthcoming overview, you can see there is a wide range of external beam in these patients from 37.5 Gray and 15 fractions up to 45 Gray and 25 fractions, and the brachytherapy is given in 3 fractions are 15 Gray and also in 1 fraction 12 to 15 Gray. So for the moment nobody knows clearly what is the best way to go, but it is clear that HDR brachytherapy is a very valuable tool in the hands of experienced colleagues. So when we are now coming to locally advanced tumors following radical prostatectomy, the problem of all locally advanced PCA, that means T3 tumors normal-wise, after radical prostatectomy within 5 years you have up to 50% of progression, of biochemical progression. That means a PSA increase, showing that the tumor recurs. And also after the combination of irradiation plus ADT, you have also comparable up to 50% of tumor progression within 5 years. And the most interesting point is after radical prostatectomy, and now we are dealing with the point after radical prostatectomy, means a PSA increase really that it is a local disease? And this is a very nice but very old study, but it's actual, published between 1999 and 1989. These are all patients with a PSA increase after radical prostatectomy and no clinical sign of tumor. And when they had a biopsy at the vesico-urethral anastomosis without signs of tumor, in up to 54% of the patients there was tumor that could be found in the biopsy. And where are the typical sites of local recurrences after radical prostatectomy? It's a very nice paper coming from Peter Portmans from the Netherlands, and you can see that the site of the recurrences are lying within the region of the anastomosis here, where it is expected when it is treated in this region. So what we have to look, the positive surgical margin after radical prostatectomy is very common. This is one of the major series published by Stevenson in 2009. What you can see that a group of altogether 7,000 patients after radical prostatectomy were investigated retrospectively, and 1,500 had positive surgical margins. And you can see very clearly in the follow-up, when nothing was done, only a wait-and-see strategy, that after 5 years you have a huge difference of about 30% more progression for these patients who had positive surgical margins. And when you are looking for the extent of the margin, is there a difference of a huge margin with about 10 millimeters compared with an extent of the margin of about 1 millimeter? We can clearly say yes. And even the patients with the very small positive surgical margins had a negative influence on the biochemical progression-free survival. So, margin matter. There are 3 randomized clinical trials, prospective randomized trials, one coming from the US Southwestern Oncology Group, one coming from the EORTC, and also one from the German Cancer Society, published in the time between 2006 and 2010. And the first important of these trials had 470 patients treated very early up to 1995. And these patients had PT3 tumors after radical prostatectomy. And the one group of the patients had wait and see only, and the others had an irradiation of 60 Gray. It is important that these patients had no central pathology. What was very important after a median follow-up of 12 years, that there was a survival advantage in favor of the patients with adjuvant radiotherapy, with a prolongation of overall survival of more than 1.5 years in favor of the additional adjuvant irradiation. The second randomized trial had 1,000 patients coming from the European Community, from the EORTC, and we had the same one Mostly of the 1,000 patients, 900 had PT3 tumors, but there were also 100 patients with PT2 positive margin tumors, and one group had only wait and see, and the other group had 60 Gray to the prostatic bed. Important is that the PSA was not 0 after radical prostatectomy. A median before radiotherapy it was 0.2, and with a median follow-up of 10 years there was a clear advantage of biochemical progression, about absolutely 20%, and nearby significant but even not significant 0.054 due to clinical progression. But there was no difference in overall survival in contrast to the SWOG trial. And very important was that from this trial there was the central pathology review later on from 11 European centers with 550 out of 1,000 patients. And what Theo van der Kwast clearly pointed out was that when a central pathology was done, then these patients who had in central pathology positive surgical margins had the most benefit from adjuvant irradiation, absolutely 30% of additional 60 Gray. But this was only seen in these patients with additional central pathological reflux. The third trial is coming from Germany. Up to 2004, altogether 388 patients were randomized. And what is different, in contrast to the other trials, is that the patient who had persistent PSA after radical prostatectomy were excluded from the study, and only these with undetectable PSA were then treated with 60 Gray compared to a wait-and-see strategy. And in this study there was a central pathological review at the time of diagnosis. Altogether, 86% of the patients had central pathological review. Median follow-up with the first publication in 2009 was 5 years. And these are the 10-year data published in 2014 in European Urology. And the primary endpoint was biochemical progression-free survival. And there was a highly significant advantage of absolutely 20% in favor of adjuvant irradiation for these all PT3 tumor patients. In a subgroup analysis, that's not the primary endpoint, but it was a subgroup analysis of these with positive surgical margins, there was a even more highly significant difference. These patients who were adjuvantly treated with 60 Gray had more than a double better biochemical progression-free survival after a median follow-up of 10 years. But again, no difference in overall survival. But this trial was not powered for overall survival because it was not the primary endpoint. When we have a look into the side effects of the last trial, because it is a more modern trial, then you see that acute side effects grade 1 and 2 appear in about 12%, which is very low, and only 3% grade 3 acute side effects, and only 1% grade 3 late side effects. So with 60 Gray, and this was 3D treatment planning, you have a very low rate of side effects. In contrast, you can say, okay, we can treat the patients adjuvantly when the PSA decreases in the undetectable range, and then we made adjuvant irradiation. But on the other hand, you can say, can we also treat these patients when the PSA increase after radical prostatectomy, and we can spare a lot of patients adjuvant treatment? Of course, you have with every adjuvant treatment a risk of overtreatment, that you treat patients who don't need really this treatment. This is a landmark series published in 2007, Radiotherapy for PSA Increase After Radical Prostatectomy, a pooled series of, it's a series of more than 10 American centers, 16 contributors, and the median dose was 66 Gray to the prostatic fossa. Median follow-up was 4 years, and what is important is shown here. You can see that when the patients were treated before the PSA was 0.5, the blue line, compared with these who started when the PSA was more than 1.5, after 5 years you had a 40% better biochemical progression-free survival. So it means clearly when you start the so-called salvage irradiation, started very early, at best for the moment before the PSA comes over 0.5. This is a series from our own group published in Radiotherapy Oncology in 2012. 301 patients had salvage irradiation, and the point is that these patients had a median pre-SRT PSA of 0.3, which is very low and below the 0.5 for the recommendation you have seen just before. And what you can see in the retrospective analysis, 150 patients were treated before it was 0.3 and the others later on, and there was a clear significant advantage in favor of these patients who were treated more early. And very important, the patients who had after irradiation, after salvage radiotherapy, and gain an undetectable PSA had a real chance of cure. On the other hand, this was biochemical progression. There is one study published in JAMA 2008 who demonstrated an improvement of PSA-specific survival for salvage radiotherapy compared with wait and see. It was a retrospective study. 635 men with biochemical progression after radical prostatectomy. 160 had salvage radiotherapy alone, and nearby 400 had only a wait-and-see strategy. And what you can see here, that these patients with salvage irradiation compared with these with the wait-and-see strategy, there was a clear, significant, better prostate cancer-specific survival for these who were treated early with salvage irradiation. Important to know is what is the median time until PSA after salvage radiotherapy comes in an undetectable range again, because you have to inform the patient about this fact. And when in these two series published in high-ranked journals, you had about 200 patients with a median PSA of 0.7 before start of salvage radiotherapy. And the decrease from 0.7 to below 0.1 was in the median 8 to 12 months. So the patient has to be informed that he has to wait a long time until the PSA decreases. And that is no bad sign. Again, looking into the ERU guidelines on prostate cancer published in 2014, you can see here the comprehensive overview of what I had shown you before. What is the best? Which is the best, adjuvant irradiation or salvage irradiation? The point is that you have to treat the patient in the best way. There are clear indications for adjuvant radiotherapy for PT3 tumors with positive surgical margins and, for example, with Gleason score of 8 to 10, and you have clear indications where you can wait until the PSA increases, and when you have a very early salvage radiotherapy, this is an open question what is the best treatment at the moment. But, which is important, this has to be discussed in the tumor board, which is ideally constructed at every major clinic. What are the side effects of definitive irradiation without antihormonal treatment? These are more early serious. If you give with modern treatment techniques like IMRT up to 72 Gray, you have a very low rate of below 3% severe side effects, acute side effects. And late side effects with the older techniques, you have 2 to 3% grade 3, which is severe, and you have an up to 50% in between 5 years of erectile dysfunction. When we now have a look into the more modern techniques like IMRT, this is again the Memorial Sloan Kettering Cancer Center, a median follow-up of 8 years looking for side effects with 81 Gray. And you see that after 10 years, the gastrointestinal side effects are no longer the problem of irradiation. Only 1% of severe side effects. But the problem is coming, or is now again, the genitourinary late side effects, with about 5% of grade 3 side effects of the genitourinary system, which is very high. And when we are looking into the detail in this very important paper published in 2008, altogether more than 1,000 patients treated with up to 81 Gray in New York. And you can see in the follow-up here 10 years, 15 years, and you can see the rate of grade 2 plus genitourinary side effects. And you see that even after 10 years up to 15 years, it increases up to 20% of these patients. These patients were not treated with IGRT, as I have shown you formerly. And when they are treated with IGRT, the side effects come down, but they are even for the moment about in this region. And this is also not neglectable. So this is a problem of IMRT, the risk of genitourinary late side effects. What is with erectile dysfunction after RT? It's clearly known that 5 years after RT, about up to 50% of the patients will have erectile dysfunction. But there are 2 small randomized trials, but double-blind placebo-controlled, using sildenafil and tadalafil, and they show very clearly that in up to 60% of these patients there was a significant improvement of the erectile dysfunction in these patients. And a newly published journey, again coming from the Memorial Sloan Kettering Cancer Center, they tested something what has been known very well after radical prostatectomy. The prophylactic sildenafil citrate can improve select aspects of sexual function in patients treated with radiotherapy alone. It was a phase 3 double-blind study, placebo-controlled, and all these patients had sildenafil 50 milligram per day for a time of 6 months during and after irradiation. The dose was 86 Gray, which is very high. And they also should show very nicely that after 12 months there was a clear, significant improvement of the erectile function score, but it disappeared after 24 months, which is not astonishing because the additional sildenafil was given only for 6 months during and after irradiation. So in the near future, for example, sildenafil will give more in these patients who have erectile dysfunction after irradiation of the prostate cancer. After radical prostatectomy, adjuvant and salvage irradiation has a comparable low rate of side effects, a very low rate of grade 3 to 4 side effects, for example, as shown in the ARROW trial, the German adjuvant irradiation trial. So this is a clear to treat these patients after radical prostatectomy in the best way. What we have to take into mind is that since the bomb of Hiroshima and Nagasaki in the 1914s done by the Americans in Japan, it is clearly known that in the long-term follow-up of irradiated patients there will appear radiation-induced secondary cancers. And to have a look into the magnitude of this, you can look into the SEER database, which is a big database coming from the US. You can show here patients with no RT, no surgery, about 40,000 patients, and you see patients with secondary tumors, not induced tumors, without any irradiation is about 8% after 5 years. And when you are looking for patients who had radiation therapy alone, these are about 70,000 patients, you can see that after 5 years these 8% increased to 8.8%. So after 5 years there is an increase of radiation-induced tumors, but with this, in this time frame, it's very low. The real radiation-induced tumors in this short follow-up is only about 0.2, but it is well known that it increases over the years, and in between 15 years you will have a risk of about 1% in these patients. But you have to take in your mind that the median age of the irradiated patients for prostate cancer is about 68 years. So overall, in conclusion, HDR brachytherapy is a clear option for locally advanced prostate cancer, but it has to be used in the hands of very experienced persons. Adjuvant radiotherapy, called ART, increases biochemical no evidence of disease and possibly overall survival after radical prostatectomy of PT3 positive margins. But for the moment it's not known if salvage radiotherapy, when it starts very early, is as good as adjuvant radiotherapy or not. With IMRT and IGRT there is a low rate of severe side effects, of severe late side effects, and the risk of tumor induction after radiotherapy is moderately increased within the first 5 years, but increases later on. Now we are at the end of the unit of radiotherapy for prostate cancer, and I do hope that you enjoyed the theme. Thank you.